Everybody. This is Jackie Sharp with the Department of Education, Office of Family and Community Support, and I have with me Dawn Ayers from our office as well. And I just kind of wanted to welcome everybody this morning and say that I think we're in store for receiving some very valuable information today. It's been a work in progress. Just wanted to cover a few logistics. I think that most of the people who had registered on STARS received a PowerPoint presentation on Wednesday. That PowerPoint has been revised, and I will provide the revised PowerPoint after the webinar. But I think we'll be good enough to go for today. I also want to say that the actual HIV Toolkit is posted on ODE's website. And at the conclusion of the webinar, there's information there on how to access that if you've been unable to do so thus far. I would ask that, I'll keep you guys muted until the end when we'll have hopefully 10 minutes or so to do some questions and answers. If for some reason at the conclusion of the webinar we haven't been able to address everybody's questions, we'll track those questions and provide an FAQ after the webinar as well. So with that, if you guys have any questions, you can type in the chat box those questions, and if any of them are like individual questions that we can answer as we go, we will. If it's a group one, we'll go ahead and answer those as a group later or at the end of the webinar. So we can just kind of stay on track and keep the information flowing. So at this time, I just wanted to briefly mention a few things about the development of the toolkit. These policy guidelines were developed for school districts to ensure the health and safety of students and school staff. While HIV transmission in the school setting is unlikely, adherence to the content in these guidelines will ensure a comprehensive approach to HIV prevention in schools and further reduce the possibility of transmission. The elements are comprehensive in that they cover things such as universal precaution practices, safe and supportive learning environments, and rights of students and staff. These guidelines are just that. They are guidelines. They are not mandated by the state. They were developed to provide districts with guidance in developing a district-wide HIV policy. These guidelines provide essential information to administrators, nurses, educators, parents, and students. They were developed after an extensive literature and data review and is modeled after the National Association of School Boards of Education guidelines. The toolkit itself was vetted to various health, education, and medical provider groups across the state and was reviewed by and approved by the Ohio's HIV Education Materials Review Panel, which is actually a requirement of the Center for Disease Control and Prevention. It was also reviewed by the National Association of School Boards of Education. So lots of eyes have been on the toolkit, and it's been, as I say, a work in progress, and the two folks behind the development of the tool are Paula Braverman and Keith King, and I'd like to just take a minute and introduce them before I hand it over. Paula works at the Cincinnati Children's Hospital and is a professor at the University of Cincinnati College of Medicine with special interest in adolescent reproductive health, sexually transmitted diseases, juvenile justice, and behavior approaches to risk reduction. She's very active with the Academy of Pediatrics and provides passion and expertise on many statewide health and education initiatives. Keith is a professor of health promotion and education at the University of Cincinnati. He serves as a cadre of trainers member for the Ohio Department of Education through the Buckeye Healthy Schools Alliance and has gained national recognition for his work in adolescent health promotion, specifically related to suicide, violence, and substance abuse prevention, school health education, sexuality education, and teen pregnancy prevention, as well as survey development and program evaluation. So I'm going to turn it over to Keith and Paula, and again, if you have any questions or having any technical difficulties, you can go ahead and attempt to place those in the chat box on the left of your, well, I don't know if it's appearing on the left of your screen, but on the screen itself. Okay? Thanks and enjoy.
Okay. Welcome, everyone, this morning on behalf of myself and Keith to this webinar. As a start, I just wanted to let you know that the HIV guidelines are on the website for the Harvard Department of Education. And when you look at them, you'll see not only the actual guidelines themselves, but you'll also in there have links to resources regarding creating policies around these guidelines, as well as background information that would support each of the guidelines. So with that, let's start and go over our objectives. The objectives are to understand the magnitude of HIV/AIDS and sexually transmitted infections in Ohio for the adolescent age group, to be able to identify the 10 policy guidelines of a comprehensive HIV policy, and then apply the specific elements of those guidelines to your individual role in the school setting. Be able to access resources to develop a comprehensive HIV policy and HIV prevention education program, and then develop a comprehensive HIV policy. So by the end of this, we hope that you will have the information to be able to do that. We want to start off with a little bit of background epidemiology, and this first slide is data from national data from 2009. And what's really interesting about this data is that there are more than 1.14 million individuals 13 years or older who are living with HIV. And what they have found out is that they really estimate that almost 1/5 are not diagnosed. What's even more alarming is that when you look at the 13 to 24-year-old age group, which is actually considered a new cohort at risk, they actually have even a higher rate. 60% of them are considered to be undiagnosed. So when you look at the bottom part of this slide, the last two bullets, those are the number of individuals that we know, based on confidential name-based reporting, that are living with HIV or living with AIDS. But there are many more people who are estimated to have HIV who have no idea that they have the infection. And this is in part of the reason that back in 2006, the Centers for Disease Control and Prevention actually revised the HIV testing recommendations to have it be that you would test all adults and adolescents at risk annually in all healthcare settings. And they also took away some of the barriers to doing this in terms of saying that you did not need to do preventive counseling prior to testing, you did not need a separate consent form, and they recommended that it be opt-out testing, where it becomes normalized and does not become a stigma to be tested for HIV infection, but rather you make it a recommendation and have the person be able to opt out of the testing. So that is sort of the basis for why it's so important to move forward in thinking about HIV infection and really trying to determine who has that infection, because we do have treatments now that can be started early to help people live healthier lives living with HIV infection. In terms of the background epidemiology and looking at gender, there's differences in transmission whether you are male or female. So for national data for males who are 13 years or older, 2/3 of males acquire HIV infection by male-to-male sexual contact, and then that's followed by intravenous drug use, heterosexual contact, and a small portion of men who have sex with men who are also intravenous drug users. When you start looking at females aged 13 and older at diagnosis, 3/4 of them acquire HIV infection through heterosexual contact, and 1/4 of them acquire it through intravenous drug use. Almost all of youth under the age of 13 have acquired HIV infection through perinatal transmission.
Hey, Paula?
Yes.
Are you using a cell phone?
No.
Okay, because you're kind of cutting in and out a little bit. I don't know if there's anything you could do to maybe improve that a little bit.
I'll just put it right on the phone if that's easier.
Okay, we'll see if that works.
You know, actually on our end, you guys are also kind of a little bit, it's not clear, totally clear. So I wonder if part of it is also the line.
Okay. So. All right, well, we'll keep going, and
okay.
Hopefully, okay.
Okay. Is this better, though? I'm right on the phone?
Yeah, a little bit.
Okay, then I think it might be the line because I'm on a regular phone.
Okay.
Okay, so I'll just keep going. For all the Ohio data in 2009, so that you can compare it to the national data, you can see how many individuals in Ohio, a little over 16,000 individuals living with HIV infection, with only a tiny portion of those who are younger than age 13, and a little over 8,000 individuals living with AIDS. Again, only 20 are younger than the age of 13. And within Ohio, the transmission modes are very parallel to the national data. But in Ohio, 100% of AIDS cases for youth under the age of 13 in 2009 were from perinatal transmission. So what about this age group that we're talking about? What about some of the other epidemiologic factors? One thing that's concerning is that 1/4 of all new infections in the United States in Ohio in the year 2010 occurred in individuals aged 13 to 24. This is also the age group that has among the highest rates of sexually transmitted infections, and this also parallels the rate of new other STI infections in this age group. In both the United States and in Ohio as a state, males were more likely to be diagnosed newly with HIV infection than females. And similar to national data, there's a disproportionate amount of infections in minorities. When you look at Black African American, 44% of all new HIV infections in the United States are in Black African Americans, and in Ohio, 49% are. And when you actually look at rate comparisons by race, ethnicity, African Americans are 7 times more likely than whites to be diagnosed with HIV infection, and Hispanic Latino are 3 times more likely, both the United States and Ohio, to be diagnosed with HIV infection. In terms of looking overall epidemiologically at that 2009 Ohio data, you can just see by age group how many individuals in that 13 to 24-year-old age group are living with HIV. And then this slide, just for your reference, again, just reiterates what I just talked about transmission status, where number 1 in males is men who have sex with men, and number 1 in females is heterosexual contact. And then in females, number 2 is actually intravenous drug use, even though in males, that's number 3. So what about adolescents and the risk factors for HIV infection? Well, certainly sexual activity, other sexually transmitted infections, and substance use are known to be risk factors. When you look at the 2011 Ohio YRBS data, that's Youth Risk Behavior Survey data, you can see that a little over 1/2 of 9th to 12th graders have ever been sexually active, and almost 42% are currently sexually active, meaning at the time of that survey, they had been sexually active in the past 3 months. In addition, looking at the youngest age groups, less than 13, already 6% of those under age 13 have been sexually active. And almost 1 out of 5 youth in Ohio in 9th to 12th grade have had 4 or more lifetime partners. And of course, the more lifetime partners you have, the more likely you are to acquire a sexually transmitted infection and or HIV infection. What about the data for STIs in Ohio for adolescents? When you look at chlamydia, gonorrhea, and syphilis, 15 to 24-year-olds have among the highest rates. And again, you have that disparity in terms of blacks having much higher rates compared to whites. Also, in terms of substance abuse in 2011 YRBS data, you can see that almost 1 in 5 youth drank alcohol or used drugs before last sex. So why is that important? It's important because we know that use of drugs or other substances, such as alcohol, before sex makes it more likely for you to have riskier sex, not use condoms, make poor judgment about the partner and the number of partners that you're having. And then 3% of youth in Ohio in 2011 actually have a history of intravenous drug use, of course, which is one of the major risk factors for HIV infection. The other thing that's unique about adolescents is the biology as well as their cognitive and psychosocial development. So biologically, the adolescent females have a normal biologic immaturity of the cervix. And this is something that by the time they hit adulthood has matured. But during adolescence, there's something called the ectropion that is present on the outside of the cervix. and that makes them more vulnerable to acquiring STDs, and in some cases more vulnerable to the consequences of acquiring sexually transmitted infections. Also in adolescence, it's not uncommon for females to be several years younger than their male partners. And that creates an inequality in the relationship, particularly at a time when developmentally they may not be at the same place in terms of their cognitive and psychosocial development. So it makes it more difficult for the females to say no to sexual activity and also to negotiate condom use effectively. It's also been shown that females may not recognize their male partner risk factors. They may not realize that they're actually with a male partner who has had other partners who may have a sexually transmitted infection. There may not be that communication. But also, they've shown in studies of men who have sex with men, they may not want to disclose their sexual orientation to their female partners, which is why females may also be at higher risk for acquiring HIV infection from heterosexual transmission. In terms of the normal adolescent cognitive and psychosocial development, we know that adolescents, particularly the youth who are under the age of 16, are really transitioning from more concrete to abstract thought. They really feel that they're invulnerable to harm. Nothing bad's going to happen to them. They take risks because they truly believe that they're safe and nothing will happen. They also really can't really put their current behavior in perspective for the future, and really do not understand or appreciate the fact that their current behavior may impact what happens to them in the future. We also know that teenagers are much less adherent to therapy. That includes everything from their asthma therapy, but of course that raises a lot of concerns in terms of something like heart HIV therapy, because it's really important to be very consistent when taking those medications. And then you have all those youth that were perinatally infected, or youth who become positive during adolescence, who really have to face decisions about becoming sexually active, about disclosing their HIV status to their partners, and then what to do about protecting their partners from acquiring HIV infection. So all of this is complicated for adults, but becomes even more complicated for adolescents who are really not mature yet in terms of their cognitive and psychosocial development. So this all leads us to the toolkit, and I just want to give a little bit of background before we go into the policies in this document around sexuality, HIV prevention education in schools. So the first thing goes to the type of sexuality education, and there have been many studies that have been done that show that comprehensive sexuality education, which includes abstinence messages as well as information on how to prevent pregnancy and sexually transmitted infections and HIV infection, have been the most effective in multiple areas, including delaying sexual debut, reducing the number of partners, decreasing the frequency of sex, and reducing unprotected sex, and increasing condom use and other contraceptives when youth are sexually active. It's also important to look at the type of program that's being delivered. So when Kirby looked at the characteristics of effective programs, he found that those programs were based on theoretical models, that they address both risk and protective factors. So one very important protective factor, of course, and it's included in these policies, is that involvement of parents and parental monitoring of youth are protective factors in terms of risk behaviors. It addresses the needs of the target group and is consistent with community values and resources. So that includes involving families as well as people in the schools and the community in terms of that programming. It creates a safe social environment for learning and has activities that are both age and culturally appropriate. So what's appropriate for a 5th grader or 6th grader is not going to be the same thing that's appropriate necessarily for an 11th or 12th grader. And similarly, what's appropriate for a 1st or 2nd grader is not going to be the same as the older youth. It addresses not just knowledge, because we know that knowledge is not sufficient to change behavior. It also addresses their attitudes, the values they place, their self-efficacy, meaning the belief that they can actually engage in that behavior, and then ultimately affects the behavior itself. And it has the support of the appropriate authorities. And that would mean, in this case, as we're talking about schools, that would mean people within the schools and the school district. What do we know about the extent of sexuality and HIV prevention education in Ohio? Well, the 2012 school health profiles from ODE and ODH show that only about one-half of schools in Ohio had a policy that addressed attendance of students with HIV infection. About 59% of schools had a policy protecting infected students and staff from discrimination. Less than 2/3 of all schools required courses for grades 6 through 8 to teach how to prevent HIV, other STDs, and pregnancy. Whereas when you go to 9th to 12th grade, 95%, almost all the schools require courses on these topics. When you look at the type of information that's taught in junior and senior high schools, greater than 80% do talk about the relationship between HIV and other sexually transmitted infections and pregnancy, as well as the relationship between drug and alcohol use and HIV, STIs, and pregnancy. They also cover the benefits of abstinence and how to prevent HIV, STIs, and pregnancy, and go into the important aspects that are in National Health Education guidelines in terms of media, family, social, and cultural norms, and actually getting into the skills of communication, negotiation around reducing HIV, STI, and pregnancy risk. However, saying that, there remains a lot of administrator anxiety to teaching about these sensitive issues, despite the fact that surveys, including recent ones in Ohio, show that the majority of parents favor sexuality education in both high school and in middle school. Unfortunately, and something that we really need to improve on, is that many teachers do not feel prepared actually to teach certain topics. In fact, when it comes to elementary school education, only 2% of elementary education majors have a required course in sexuality education. And even only 14% of colleges require education majors to take a sexuality education course. And then when you look at staff development and continuing education, only 1 out of 5 sexuality HIV prevention teachers actually had staff development specifically on HIV prevention. Finally, we talked about a little bit earlier the importance of including parents. Many school-based programs don't include parents. And this is despite the fact that multiple surveys over many years have shown that parents are actually the primary desired source of sexuality info by teenagers. So the other thing I think it's important to look at is not just the topics that are covered, but looking at the specifics of those topics. So this slide here is showing you that there's a big difference between what is given to junior combination senior high schools versus high school students. So you can see that the older youth are much more likely to have education on the efficacy of condoms, how that is important to correctly and consistently use condoms. But even when you look at this last thing on this chart, you can see that despite getting that education, even in the older grades, less than 50% of youth are actually told how to obtain condoms. So they're told it's important to do it, they're told condoms will be effective, but they're actually not told how to operationalize that in terms of how to actually get the condoms to utilize for those purposes. So at this point, I'm going to turn it over to Keith, who's going to continue on with the next set of slides.
Thank you, Paula. The National Health Education Standards were developed by the Joint Commission on National Health Education Standards. They serve as a framework for health education curriculum development and actually are essential in setting concrete measurable expectations and helping to ensure that we're working to go ahead and increase knowledge, attitudes, and healthy behaviors among youth. So the functional knowledge of ideas, concepts, skills to adopt, practice, and maintain healthy behaviors is essential. It includes personal values, group norms to support healthy behaviors, and an emphasis on how to access valid health information, which we know that our students and our youth want and oftentimes don't know how to actually access quality and credible health information. These are both content-oriented as well as skill-based, and so that's very, very important to remember. There is a toolkit, actually. There's a tool. It's called the Health Education Curriculum Analysis Tool, the HECAT, that I'm certain that many of you have already used to go ahead and kind of assess where exactly your schools are with respect to health education and the curriculum that is actually being covered. This incorporates elements of effective curriculum, provides age-appropriate, developmentally appropriate information, learning strategies, teaching methods and materials, and outlines sequential reinforced concepts and skills that go all the way from pre-K through 12 to ensure that youth are receiving age-appropriate and culturally appropriate education. One thing that we wanted to go ahead and continue to underscore the importance of is the importance of school connectedness and school climate on overall youth health status, youth mental health, and also their academic achievement. What is extremely clear from the research, actually from the National Longitudinal Study on Adolescent Health, one of the largest studies to date that examined adolescent health issues, they went ahead and examined 8 risky behaviors and then sought to identify what is the leading protective factor against youth involvement in risky behaviors such as suicidality, depression, violence, alcohol, tobacco, marijuana use, early sexual involvement, and teen pregnancy. And what they found out was inside of the school, in the school arena, school connectedness was the leading protective factor against all of those risky behaviors. So it's extremely important to go ahead and try to get our youth positively connected to the school. And that's all youth. And so what we have seen is when they do not feel connected positively, then they tend to go ahead and show an increased likelihood to get involved in unhealthy behaviors, school dropout, and academic achievement suffers. There needs to be a concerted effort also in the positive school climate, which is associated with lower rates of student involvement in unhealthy behaviors. And when looking at that inside of the school, to ensure that there are caring and supportive relationships in the school from school teachers, school staff, all school professionals that are involved with the youth. There need to be opportunities for the youth to become involved in school activities, shared norms, values, and goals. And we do know that the research also shows that those youth that are more involved in school activities and community activities are significantly less likely to be engaged in risky and unhealthy behaviors. So this brings us to the actual toolkit and the need for the school HIV/AIDS prevention guidelines and toolkit. And Jackie kind of mentioned that at the very beginning. These guidelines are on how to effectively deliver HIV/AIDS prevention education to students in elementary, middle, and high schools. But the policy guidelines also help to provide guidance and direction to schools regarding school, staff, and student issues related to HIV/AIDS. The toolkit, as Paula mentioned, the toolkit does have resources. There are websites available for sample policy statements that we went ahead and put, we attached to ensure that you would have all the materials and all the information that you needed to go ahead and implement your school policies. So these are policy guidelines that we went ahead and developed and then vetted throughout the state. So we developed 10 Ohio School HIV/AIDS policy guidelines, and you can see them listed there all the way from communication plan to policy review and information dissemination. I'm going to go through each one of these and just say a few words about each one and what they mean and their most essential components of each of the policy guidelines. Again, these are guidelines. So Ohio has home rule. So these are simply guidelines, but these are based on a comprehensive review of the literature, and so they are research supported, and they were based on the National, the School Board Association as well. And so with that, we wanted to ensure that y'all were getting quality and credible research-supported information. Starts out with communication plan. The policy guideline 1 is the communication plan. And in traveling throughout the state, it was interesting to actually see and find out how many schools actually didn't have a specific communication plan developed or established. And so with that, there really does need to be a clear and clearly delineated communication plan that will be established to address school board members, parents, and community concerns and questions regarding HIV prevention. How exactly is this going to be addressed in the school, all the way down to the classroom, to the building, to the district level? How will it be addressed? And so there needs to be clear communication plans established and clear protocols established. The plan is to be clearly articulated with detailed steps in disseminating information concerning policies regarding HIV/AIDS and HIV/AIDS prevention education curricula. And in addition, we know that parents are extremely important. Obviously, from the coordinated school health education model, one of those components is the importance of parent, school, and community partnerships. And so in order to go ahead and attain parent buy-in and parental support. One of the best ways to do that is to go ahead and ensure that parents are brought in at the very beginning to be provided with opportunities to preview and review the HIV/AIDS prevention education curricula that's taught in the schools, as well as the policies. Parents could be given the opportunity to have their child exempted from the HIV prevention sexuality lessons taught through the health curriculum. So that is, they have that opportunity to go ahead and opt out, if you will. This policy component helps to develop quality school, family, and community partnerships, as I mentioned. It's identified within the Coordinated School Health Education Model from the Centers for Disease Control. The policy guideline 2 is the right of students and staff to attend school and participate in school-sponsored activities, including athletic programs. And this specific policy guideline, as we mentioned, we vetted all of these guidelines throughout the state with different types of professionals, and this one was an interesting one that was vetted and heavily vetted to ensure that this met all the necessary criteria. Each student and staff has the same right to attend school and participate in school-sponsored activities. All students have that right, okay? All students should be subject to the same rules and policies concerning school rules, class projects, assignments, privileges, participation, including school-sponsored physical activities. This also includes student participation in physical education classes, as well as sports, athletic programs, and recess. Those specific activities are not conditional or dependent upon a student's HIV status at all. And these days we have, in talking about athletic, involvement and sports involvement, in vetting this specific guideline, there were questions about, well, what happens if a youth, is involved in let's say, a basketball game and then they start bleeding, what happens then? Well, that's specific just practicing universal precautions, and so there's specific protocol that are in place to go ahead and ensure that the individual is obviously taken out of the game and then the blood is taken care of, and then there's a Band-Aid or what have you to go ahead. It's just universal precautions. And that would be followed basic with bloodborne pathogen training. All staff members, volunteers, and school-related personnel should be subject to the same rules and policies. And when looking at this further, HIV status should not be considered when making decisions regarding participation in class projects, assignments, and school activities. Mentioned that, as well as recess. Students are not required to disclose HIV status in order to participate into physical education classes or sports or athletic programs in recess. They're not required to disclose their status at all. The policy component addresses potential issues of school staff respect, as well as discrimination and stigma that are associated with HIV/AIDS. Policy Guideline 3 reinforces the importance of developing a respectful school climate, which really at the heart of this is trying to ensure that we continue to go ahead and take fervent steps to increase school connectedness amongst students, also among staff as well. So it's very clear, if we can get all folks positively connected to the school and to each other inside of the school, there's going to be significant declines in a lot of risky behavior involvement. School district and staff will diligently seek to establish and maintain a respectful school climate for all students and for staff. The district and staff will encourage students and other staff members to be respectful of all individuals regardless of HIV status. School district and staff will discourage and not condone discriminatory or harmful statements made to students and other staff members regarding HIV status. Still to this day, even though the research is completely contrary to this, there often are specific sexual orientation comments that are made with respect to HIV status, and we know very clearly that HIV can be transmitted from same-sex and opposite-sex behaviors, and so it is not just specific to same-sex behaviors. That's absolutely that's incorrect. Regardless of that, all schools should be going ahead and making efforts to try to go ahead and decrease some of the discriminatory and harmful statements that are made to students regarding a variety of issues, and just one of them would be HIV status. We have seen increases in bullying throughout the nation. That is a major problem these days. I'm certain many of you have seen that in the press as well as in your schools. There are increases, especially with respect to cyberbullying. That has absolutely skyrocketed these days, and it's a whole new animal that we're trying to go ahead and attack and address, that whole problem. So there needs to be steps to go ahead and prohibit bullying, harassment, and intimidation directed towards students or other staff members, just in general. just trying to decrease bullying and overall school violence in general. We do know that a sizable percentage of students that actually do stay away from school are staying away from school because they are afraid that they will be the victims of some type of violent act or bullying. This policy component assists in developing a healthy school environment, which is a key component of coordinated school health education. Guideline 4 addresses the right to employment for school staff. So we're specifically focusing on school staff here, and the district and the board cannot use hiring practices that discriminate on the basis of HIV status. The school district and school board cannot terminate school staff based on HIV status. The policy is in complete accord with the Americans with Disabilities Act of 1990. It ensures that staff will not be terminated based on HIV status, provided that they are able to adequately perform the tasks and responsibilities of their position. The policy component addresses issues of discrimination, respect, and also stigma. There's also right to privacy for students as well as right to privacy for school staff. Students and school staff are not required to disclose their HIV status, as I mentioned. That is for both students and school staff. HIV antibody testing is not required. It cannot be mandated for any student or school staff. As well as these guidelines are policy guidelines and are not mandated. So they're guidelines. School staff cannot disclose to another person the HIV status of a student or a staff member. Violation of medical privacy is cause for disciplinary action. And no information regarding HIV status of a student or school staff will be disclosed without a court order or written, signed, and dated consent of individuals infected with HIV. With that, all health records, this is specific when you're talking about school health professionals, all health records documents containing information about a student or staff member's HIV status, they should be kept in a locked and secure location. In order to do that, that will go ahead and ensure that the information will be kept private and confidential. Access to the confidential medical information will be limited. It will be limited to emergency professionals and those identified by that individual, and in the case of a minor, a student, those individuals by their parent, those identified by their parent or their legal guardian. The guidelines must adhere to HIPAA and the FERPA standards. The policy component addresses issues of confidentiality. Policy Guideline 6 involves practicing universal precautions, as I mentioned a few slides ago. All employees are required to follow basic infection control guidelines consistently in all settings and at all times, including playgrounds and school buses. It includes the specific school setting inside the school, as well as the school grounds, as well as mentioned here, school buses. The U.S. Department of Occupational Health and Safety Administration precautions should be followed. If the universal precautions are practiced, then there really is no need for additional concern regarding HIV. And that statement actually should be bolded, because in vetting these and sharing this and presenting this throughout the state, we had to consistently go back and just continuously reinforce if universal precautions are practiced, there really is no need for additional concern regarding HIV, and sharing that with parents and staff and school teachers and so forth. It's just important that they know the basic facts associated with HIV transmission. The individual responsible for health and safety in the school will be notified if the behavior or health condition of a student or staff member, regardless of known HIV status, places others at risk for infection. Again, going straight back to universal precautions. If a student or staff member is exposed to a potential infectious agent, then the authority responsible for health and safety will recommend that the individual will receive appropriate medical evaluation, and in the case of a minor, the parents should be informed of the incident right away. This addresses infection control guidelines and universal precautions. In Guideline 7, we get into the actual education and then some curricular issues. HIV prevention education should be taught in the context of a comprehensive K through 12 school health curriculum that focuses on building health literacy, functional health knowledge, and that focuses on health promotion and primary prevention. One of the keys of HIV prevention education is to start early and to ensure that we're providing the youth with content so they know the facts associated with HIV prevention education, as well as skills and preventive types of skills. So the HIV prevention education is to be evidence-based, which is research-supported, medically accurate, age-appropriate, taught in K through 12, as I mentioned, increasing knowledge and skills, being part of a comprehensive sex education program. integrated into the district curriculum. It is to be inclusive for all individuals and engage parents and guardians to review educational programming. Again, what we have found is in just sharing basic information up front with parents and letting them know this is what we're doing, this is what the plan is before doing it, there's much more parent buy-in and less problems down the road than just going ahead and putting in the educational program and then letting the parents know afterwards. Parents have the option here to go ahead and opt their child out as well. HIV prevention education will follow the National Health Education Guidelines. HIV prevention education will be taught by a qualified professional certified in school health education and or trained on HIV/AIDS prevention education. I mentioned earlier the importance of school, community, and family partnerships. That brings us to Policy Guideline 8, which is collaboration with clinical services. And it's important that the schools in the district and the district overall are familiar with the clinical services in that area, as well as should be collaborating with that specific clinic-based services. So working with community and clinic-based services, including community-based organizations, hospitals, clinics, school-based health clinics, school-linked health clinics, providing students with information on how they can access intervention and health services when they're on school grounds or off school grounds. The district will establish linkages and linkage protocols for referring students to external supports and services in the greater community, such as culturally responsive and respectful HIV STD testing, culturally responsive and respectful HIV/AIDS care and prevention services. There needs to be collaboration here with the schools and the community services that are out there. Policy Guideline 9 is on staff development and training to ensure that there is consistent staff development and that all school professionals and staff are educated on the facts associated with HIV transmission, treatment, and so forth. The district will provide annual in-service trainings for school staff, volunteers, and school-related staff on current law, district policy, and HIV transmission, treatment research updates. It's important to go ahead and provide that annual in-service training. Since there is turnover, there's a lot of staff turnover, and sometimes staff that were brought on maybe last year or so didn't get the training. The district will provide in-service training for all newly hired school staff on current law, district policy, and HIV transmission treatment research. And select staff will receive additional information and training on HIV/AIDS prevention and education based on their specific positions. For instance, obviously health teachers that may be delivering the actual health education to the students, school nurses, school counselors, et cetera. The policy component supports professional development on HIV/AIDS prevention in the school. And then Policy Guideline 10 refers to consistently reviewing and evaluating the overall policy. So that it's policy review and information dissemination. The district would review the policy every 3 years to ensure continued effectiveness and relevance. That would also assist in ensuring that the policy is staying current and it is up to date. School administrators and officials will notify students, parents, and family members regarding changes or modification to the school policies regarding HIV prevention. That, again, keeps them in the loop and helps to go ahead and increase buy-in from families. The policy component helps to develop quality school, family, and community partnerships as identified within a coordinated school health education model. So those are the 10 policy guidelines that we have developed and kind of went through those in a nice little, hopefully not too quick of a clip, but wanted to get through those to allow us a little bit of time so that if there are questions, we could go ahead and open those up. I'm going to turn it over right now back to Jackie. Thanks.
Okay, thanks, Keith and Paula. At this time, we haven't received but just a couple of questions in the question chat box. One was in reference to, is this for board policy and what is the focus? And we were indicating that these policies are to be implemented district-wide. And so at this time, I'm going to go ahead and unmute the phones, and we'll take some questions.
Participant lines unmuted.
So do we have any questions?
Hi, yes. Thank you for that great presentation. I have a question about the in-service training. Have any of the trainings been scheduled, and how do you register for those?
In-service trainings regarding?
Pardon?
I'm not really sure what in-service trainings, are you talking about professional development?
Yes, during the presentation you talked about in-school service training for health educators, for everyone, and I was just wondering if those have been scheduled.
Well, what the policy was indicating that there would be implementation of professional development as part of the policy.
Okay.
And that would occur at the district level. The Department of Education may be providing in the future some professional development. I guess in some ways it depends on what it is you're actually looking for. If you're looking for health education, if you're looking for nursing, sexual health education, what exactly it is you're looking for.
Okay, I see. Thank you.
Yeah, though most of the professional development that the Department of Education offers, you can register through Ed Connection on ODE's website, and they announce professional developments all along the way. And then depending on your particular role in the school, we send announcements out periodically through the nurses and through the health department and so on.
We also partner with an organization called Buckeye Healthy School Alliance, and any professional developments that would be appropriate for health or phys ed teachers are advertised on their website. So you can periodically check in with them, and if you register with them, they can send you updates as to when those opportunities would be available.
Great. Thank you.
Other questions?
I have a question. Would the trainings be provided by outside agents, or would they be trained directly from staff from ODE?
I'm sorry, could you repeat the question? We were reviewing one that was posted, sorry.
Oh, sorry. Yeah, just wondering if the trainings would be offered by outside agents, or if they would be directly trained by staff from ODE.
There might, again, depending on what the topic is, it may be provided through the Department of Education, but at this time, most of the professional development is through, as Dawn mentioned, the Buckeye Healthy School Alliance and so forth, or, through the health department, through the school nurse program and those kinds of things.
But generally speaking, Jackie and myself, we don't actually conduct the trainings. We contact individuals who have expertise in different areas. Keith is one of our cadre of trainers that does offer some professional development opportunities to folks around the state, and we have a whole host of different university professionals that at different times throughout the year often offer different courses.
Okay.
And then Keith or Paula, do you want to talk about evidence-based K through 12 curricula and talk about ODH's website and the guidance that's posted there?
I'd be happy to. I saw the question actually come across, and regarding evidence-based K through 12 curricula, when we went ahead and developed, Paula and I conducted a comprehensive review of the literature, and then we looked at, Kirby is considered the expert in sex education, and in looking at some of the evidence-based sex education programs that are out there, there were 10 programs that surfaced as being evidence-based. Of those, 5 included curriculum-based programs that were effective for both males and females and had at least 2 behavioral outcomes that included delaying sexual involvement, reducing frequency of sexual involvement, reducing number of partners, increasing condom use, increasing contraceptive use, and decreasing unprotected sex. The ones that rise to the top are reducing the risk, safer choices, becoming a responsible teen, making proud choices, and then I'm going to try to pronounce this properly, Cuidate, which is spelled C-U-I-D-A-T-E, Take Care of Yourself. It's a Latino youth health promotion program. Those were the most effective programs that were out there for grades 6 through 12, specifically focusing on middle school and then high school student involvement in risky behaviors. And again, those specific programs are evidence-based. They have shown specific outcomes that are behavioral in nature, not just knowledge and attitudes, but also do have an impact on behaviors as well. Paula's going to say a little bit about the website.
This was developed with the Ohio Department of Health, and we developed specific content-based sexual health education guidelines that were comprehensive, and they addressed abstinence, as well as information about contraception, use of condoms to prevent STDs and HIV infection. And those are posted on the website for Ohio Department of Health. I guess, Jackie, can you send them out that actual link when you send them out the PowerPoint?
Okay, so one thing, well, I will definitely be sending out the PowerPoint, but also along with the registration, there was a link provided to the actual toolkit, which right now on your screen you should be able to see the link to the education department, and if you put in the HIV toolkit in the search bar, the toolkit will come up, and there are links within that will take you to a host of resources, including ODH, the Department of Health, and also to the Center for Disease Control and Prevention, which provides some guidance in terms of this particular question. Any other questions?
I had one question. Can you hear me?
Yes.
Okay. My question was a little bit about the responsibility of the districts to staff and other students. And I think the main understanding that I had was we're just thoroughly encouraging universal precautions for everyone. In the event that, there would be a transmission that would occur through something like this, I'm guessing that the responsibility would not lie on the district. If that teaching had been done and that was being followed. Is that correct?
Keith or Paula, do you want to?
I'll go ahead and I'll chime in on that. Thank you very much for the question. It's a good question. Sure. The importance is that the district has to establish policies and then enact those policies. So they're not just having policies and the policies are put in place and then they're in a book on some dusty shelf never utilized. They have to be practiced. And so in actualizing them and implementing them, if universal precautions are used and consistently practiced, then the actual likelihood of transmission is extremely, extremely low. Would you agree with me, Paula?
Yes.
Extremely low. And so with that, that's why we went ahead and developed these policies to go ahead and provide some guidance to the districts to let them know, this is really important. It's important that you have policies in place. This will help to decrease the likelihood of transmission, but also it will also hopefully help to increase the enactment of the universal precautions. Because if those are practiced, then the likelihood of actual transmission is extremely, extremely low. And so to get into the legalities of whether or not the district would be responsible or not, that's kind of an interesting question because it really does determine, or it depends upon whether or not they have a policy in place and whether or not the policy was actually followed properly.
Okay. And in fact, when you talk about universal precautions, we're talking about diseases that are actually much easier to transmit than HIV infection. So this would apply, for example, to hepatitis B infection, which is transmitted the exact same way as HIV infection, but is actually much more likely to be transmitted under similar circumstances than HIV infection.
Does that help at all?
It does. Now, in the event, and a scenario might be a child biting another child or biting a staff member, and penetrating the skin, drawing blood, possibly having open lesions in that child's mouth, then, you know, how do you go about, like, working with the family, working with the person that was bit to make sure that, you know, maybe there is no disease presence, and there was no disease transmission, just for the benefit and the assurance for that staff person?
That's where schools would, just like hospitals and other places where those kind of exposures could happen, would have policies in place with respect to testing of the individual who may have transmitted an infection, as well as the individual who may have acquired the infection. And those are usually standard policies that can be looked at and exist regarding that. But it's I just want to emphasize, in terms of a bite, for example, unless you actually break the skin and draw blood, and even in that case, the likelihood of transmitting is very, very low. But just a bite without causing major trauma like that, you're not going to be transmitting HIV infection. You really do have to have a break in the skin and bleeding. And even then, there's not that much HIV even in saliva. It's just very, very low risk compared to other bodily fluids that would transmit HIV infection.
We had questions similar to this one in the vetting of the guidelines and in the presenting of these guidelines a little while back. And one of the questions that was raised was exactly what Paula was talking about, was what happens if you have a child on the court, basketball court, and sorry about all the basketball examples, it's basketball season, I guess, but child spits at another child, you know, and, you know, what do you do in that event? And, you know, and then the spit goes into the other person's mouth or something like that. Is there likelihood that that individual could go ahead and transmit HIV and so forth? The likelihood of that is absolutely so astronomically low that we just had to go ahead and underscore how low that is. But the best thing to do is to have specific policies in place, like Paula said, so that the districts would be helping the youth, helping their staff, and also going ahead and assuring that they're going ahead and providing a safe environment.
I appreciate your information. Thank you.
Sure, thanks.
So I have that it's 12 o'clock, and I just wanted to take a moment and thank Paula and Keith for all of their hard work in presenting this, creating and presenting this information. Also, I wanted to mention again, look for emails. If you did not register and you want the information that we will be providing to those that did in terms of access to the actual toolkit and PowerPoint, please send me an email. My information is on the slide. And also look for a follow-up Survey Monkey to evaluate the workshop. And at this point, I'll say thanks and have a great day.